Hello everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own medical oncologist, Dr. Krishnamani, to spread awareness about the cancer and help patients and caregivers access the right treatment at the right time. We're diving into one of the most exciting advances in modern cancer care, tumor agnostic therapies. Unlike traditional cancer treatments that depend on where the tumor starts, like for example, the breast or the lung or the colon, tumor agnostic therapies focus on what's driving the cancer at the molecular level. These treatments target specific genetic mutations or biomarkers, regardless of the cancer's location in the body. This approach represents a major shift towards personalized, precision based cancer treatment, giving hopes to patients who previously had limited options. Without much further ado, let me introduce our doctor to you. So, he is one of the most respected voices in oncology who has been practicing at AY hospitals here in Hyderabad for over a decade, where he is known for his expertise in managing solid tumors, blood cancers, and oncological emergencies. His journey spans international fellowships and leadership roles at some of India's top cancer centers, giving him a truly global perspective on cancer care. He's also contributed immensely to the field, from shaping treatment protocols to influencing cancer care policies and driving research that actually makes a difference. But what really stands out about him is his compassionate and patient centered approach. He's not just a brilliant oncologist, but a trusted guide and ally for so many patients and families navigating the cancer journey. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And today we'll talk something about this new topic, upcoming bright one, which is based on tumor agnostic therapy.
So, can you explain to us what is tumor agnostic?
So tumor agnostic means you are looking at certain targets and those targets are responsible for the tumor growth and you are giving treatment to block those targets or to circumvent those targets.
So, why is tumor agnostic therapy called as a major breakthrough in oncology?
See, earlier how it used to be, suppose you have, what do I say? You have an ovarian cancer. You will treat all ovarian cancers with the same kind of chemotherapy, which is paclitaxel carboplatin. If they relapse, what will you say? Oh, you have relapsed. You'll use the same medication again, or you'll go for newer chemotherapies in the form of gemcitabine or lipodox. These are the names of the medicines. Now, in ovarian cancer, you are identifying a group of people who are BRCA positive. If you have BRCA1 and BRCA2, the chances of having ovarian cancer are between 15 to 40%. Okay, based on the BRCA status. So these patients are at a higher risk of ovarian cancer. Or conversely, if somebody has ovarian cancer and they are BRCA positive, they are given treatment for that BRCA in the form of a tablet called olaparib after chemotherapy so that their disease doesn't come back. So you are treating this BRCA positive ovarian cancer patient differently. You are treating a BRCA negative ovarian cancer patient differently. Okay, so you are not using a one size fits all approach. In breast cancer, for example, hormone positive, hormone negative was there from many decades. Those who are hormone positive do well. That is estrogen receptor, progesterone receptor positive. They do extremely well. They are put on tablets. Some of them can avoid chemotherapy in early or in an advanced stage also. Those who are HER2 positive receive trastuzumab or targeted therapy. Now, with tumor agnostic therapies, you are looking at specific genetic mutations and you are targeting that. That could be BRCA, that could be NTRK mutations, that could be MSI high, that could be tumor mutation burden. So, it is basically a personalized kind of treatment for cancers.
So, are these therapies useful for rare cancers or for cancers that don't respond well to standard treatments?
So this is something, so earlier how were experiments or trials conducted? 10,000 breast cancer patients, you will use a drug and you will see if it works or not. 5,000 colorectal cancer patients or 1,000 esophageal cancer patients or stomach cancer patients. So you are taking a same cancer, same stage, some 1,000 people or 5,000 or 10,000 people. Now we have done something called a basket trial, we call that. You take some stomach, you take some esophagus, you take some gallbladder, you take some sarcoma, some salivary gland tumor. But all these tumors in common have high MSI or high tumor mutation burden or NTRK expression. So you understand the cancers are different. They are not homogeneous, not breast, lung, stomach. They're all different cancers, all different cancers, but they all have one common expression, which is your tumor agnostic, which is your either microsatellite instability high or tumor mutation burden high. So what do you want? You say, though they are from different cancer groups, they have one particular what do you say, driving problem or a mutation or a fusion. And you say, I will give a drug to block it so that irrespective of what the cancer is, it will respond to because the treatment is killing the or blocking the primary cause causing the cancer. So that is why in these are called basket trials. Basket means you have multiple cancers put in a group and then you are doing the clinical trial.
Sir, when you're diagnosing, for these specific markers, what tests do you use?
See, uh, before we go into that, what I want our common people to understand is your this is precision medicine. This is personalized medicine. You are not treating all breast cancers with the same brush, all lung cancers with the same brush. Now, I told about breast cancer. You're hormone positive, you get hormone tablets. You're HER2 positive, you get targeted therapy. You're triple negative, you get chemo or immunotherapy. Now, lung cancer, smokers are different, non-smokers are different. We do EGFR ALK testing. If you're EGFR positive, you get osimertinib. If you're ALK positive, you get a drug called alectinib. So you don't need chemo, ideally. You will be put on tablets. Your survival is better. Your quality of life is better. Chemo side effects are not there. So you are treating two different lung cancer or five different lung cancer patients differently. EGFR positive with one tablet, ALK positive with another tablet, ROS with another tablet. They're all lung cancers. But one is EGFR, one is ALK, one is ROS. If everything is negative, today we saw one gentleman, everything is negative, you give chemotherapy or immunotherapy. Now you have come to the next step where you are looking even deeper. These are common cancers. In colorectal cancer, if you are KRAS, NRAS, BRAF, we say, we do the NGS. If they are RAF negative, we give a drug called panitumumab. But now you have gone even deeper. You do NGS, next generation sequencing, or complete genome profiling, or whole exome sequencing. You look at the complete tumor DNA, RNA. You look if there are hotspots. You look if there are these mutations or fusions, and you give a drug to target. So so this is across the board. Science went very deep in breast, lung, stomach cancers, endometrial cancers. Uh, but across the board, if you want to look, you will do a CGP, not only rare cancers, you do it in pancreas now, you do it in gallbladder now, you do it in cholangiocarcinomas, you do it in stomach cancers, and obviously rare varieties. Rare varieties like mammary associated breast cancer or salivary gland cancers, where we look at certain mutations called NTRK. This NTRK, for example, is required for your normal brain development. But when one part of the NTRK gene comes out and binds with another gene, it produces a protein which causes cancer. So a protein or a gene which is responsible for your normal brain development can become a rogue element and cause cancer. That is elevated in this mammary associated breast cancer or the salivary gland cancers or even radiation induced thyroid cancers. So with this test called NGS, we are looking at these NTRK fusions. We look at some FGFR fusions, mutations. We look at microsatellite instability. We look at tumor mutation burden. So the tests we do are NGS, We do IHC for MSI, which is a very simple test, but generally NGS.
Sir, can we talk a little bit on the finances required for the NGS panel testing?
Today, if you see what is NGS, it looks at the entire genome, okay, entire tumor burden or tumor, this one. So there are different, you have limited panels, you have extended panels. Limited panels means 32 genes, 16 genes, 50 genes he checks. That will be over in less than 20,000. If you want to do a 500 gene, it will probably cost you 45,000 in India. You want to send it to US to more reputed labs, they are upwards of 2 lakhs or they're close to 3 lakhs. But our Indian labs do a great job. I have never had a problem. So it is 40 to 50,000 for an extended panel also. Limited panels, you can do it below 25,000. So it is not expensive at all.
And so this testing is widely available in India.
Very much. You want it now, within half an hour, a guy will come and pick up the tumor sample. If the patient wants to give blood also, they take liquid biopsy sample also.
Okay.
So most cities it is available. It is outsourced to certain labs which are, the reports come in 3 to 4 weeks. Now certain NGS, yesterday one gentleman came to us and he said, your blood NGS, they have specialized in a test which gives you the report in 72 hours for 50 genes, which costs around 25,000. It's slightly on the expensive side, but because they give it in 3 days. Otherwise, 2 weeks, the 3 weeks, you get your NGS report. And it costs hardly 40,000, 50,000 max for 500 genes.
Sir, how effective are these therapies when you compare them to the conventional chemotherapies which are available?
I'll give you an example. I think shared this once on Cancer Age before. We had one gentleman. He's 78. He came 3 years back. He had prostate cancer, detected in 2015, underwent radiotherapy. He was doing well apparently. He was showing elsewhere in another hospital. 5 years later, his disease relapsed. It spread to the bones and the lymph nodes. He was started on all kinds of chemotherapy. He received chemotherapy, other drugs like for prostate cancer. Finally, when he came to us, he is literally on a stretcher, 76-year-old, very bad state. And chemotherapies have made his life miserable. He's in very bad state, and his disease also is bad. Now, the funny part is you have prostate cancer. In prostate cancer, there is a blood test called PSA, prostate specific antigen. Usually, when your cancer grows, the PSA should grow. Normal PSA is less than 4. His PSA always, disease is progressing on PET scan horribly, but his PSA is always less than 0.004, less than 0.001, less than 0.002. How is that possible? Either PSA is wrong or scan is wrong. Scan is obvious. You are also sick, but PSA is low. So there is a variety in prostate cancer where the disease changes its behavior and becomes aggressive after a few years. That is called small cell transformation. Okay, you change your behavior over a period of time. So if the PSA is low, but you are having a relapse, then you should work up for small cell transformation. So something was not fitting. This is number is PSA is low and disease is high. So we did a rebiopsy. And to our surprise, it to our surprise, it didn't come as small cell. It came as a transitional variant or something. So we started chemotherapy for that. But we told him, sir, this chemo also we don't know how much you will tolerate. So let us send your tumor for MSI, TMB, and NGS. You will not believe. He is MSI high, tumor mutation burden high. He was put on immunotherapy with pembrolizumab. 3 years today, perfectly fine. Scan is in complete remission. Took treatment for 1.5, 2 years, and then he's not on treatment also. He walks to the OPD, no disease. He may develop a relapse tomorrow, I don't know. Quality of life is excellent. How were you able to achieve? You didn't give chemo. You improved his survival, improved his quality of life because you had a doubt that something is not right. PSA is very low. You did a rebiopsy, sent it for NGS because on a fresh tissue only you can do NGS. or a recent block, and it was MSI TMB high. So chemotherapy is always not the mantra. This is where precision medicine or tumor agnostic therapy works for you. We have a gentleman whom I always discuss, pancreatic cancer, stage 4. We gave him chemotherapies. We said survival is less than 9 months, 11 chemos. That man was completely bedridden. He has BRCA. We put him on olaparib. 4 years today. Stage 4 pancreas. Can you believe that? He walks 10,000 steps every day. Super fit, 72, 73. So this is where your NGS helps you. You will not say that it works in 100 out of your 100 patients, but at least 10 out of 100 or 5 to 15 out of 100, it will give you some good benefit, which is not seen with chemotherapy, and potential treatment options and less toxic treatment options.
So, sir, if I were to frame another question and ask you that if there is a MSI burden, like you said, in prostate and in colon, you're giving one therapy to target the MSI. So, sir, would the responses be different for both the cancers?
So prostate MSI, how many do we see? They are very less, right? If you look at colorectal MSI, the response rates are close to 70, 75%. So compared to chemotherapy, it is way beyond. That's why today chemo is not given in MSI high colorectal cancers. It is either nivo ipilimumab or pembrolizumab.
Sir, do we face any challenges or any limitations with these tumor agnostic therapies?
Yes, side effects. Immunotherapy can lead to thyroiditis, it can lead to liver enzyme problems, it can lead to pancreatitis, it can lead to pneumonitis, diarrhea, rash, dermatitis. Your other tumor agnostic therapies like your NTRK drugs, entrectinib and all that can lead to mucositis, diarrhea, thyroid issues, pancreatic issues. So you have to watch out for all of that. No drug is without side effect.
Sir, is there any chance that a patient or like a whole population could become resistant to these therapies?
Yes, it is well known now that on immunotherapy, patients do progress, even in MSI high setting. So resistance mechanisms are there. Those patients do very poorly. Their response to chemo is also pretty poor.
Sir, how do you see tumor agnostic therapies shaping the future of cancer treatment?
Definitely, it is shaping. With the advent of new therapies like antibody drug conjugates, with more monoclonal antibodies, definitely tumor agnostic therapy is the way to go. And it also has, these tests also have some prognostic implications. Some prognostic implications. So in some cases, when your MSI high, TMB high, that means it's the tumor is good prognosis. It will respond well to treatment. You'll have a better survival. So definitely over the days to come, you're going to have more molecules, more indications. And as we do more NGS, we'll pick up more actionable mutations.
So, do you see the future of cancer therapy being more mutation or biomarker driven rather than the organ which is affected
Correct. It will be
being
more
removed?
patient oriented, more biomarker driven. It is not going to be lung cancer, treat everybody with the same brush. No.
So, can you please summarize the entire session for the audience?
So tumor agnostic therapy is you're looking for certain mutations with certain tests by commonly called NGS and giving certain treatments where you can avoid chemotherapy. So today, the common mutations we look are MSI, TMB, tumor mutation burden, NTRK mutations. These are commonly seen in thyroid cancers, salivary gland cancers, special varieties of breast cancer. But in other cancers, for example, NTRK and all is seen in less than 3% or 1%. MSI is seen in less than 5% of cancers, but commonly seen in colon, endometrium, etc. And with the use of immunotherapies and specific drugs to target these agents, the survivals are better and those patients do well.
So, can you please inform the audience about the second opinion campaign run by you?
So we have a second opinion campaign. Patients can put in their WhatsApp, patients can put it through WhatsApp, their reports, and we will reply to them. And it is basically to guide them regarding their further diagnosis or treatment.
Thank you for an interesting session today, sir. Thank you for your time. And we hope to reach you again next Friday with another important session. Thank you, sir.
Thank you so much. Bye.